think we're just going to get started exactly on time to give Lauren sufficient time to introduce our wonderful guest speaker who I've known for a long time and excited to have Jonathan here with us. So just a couple reminders. Please register for your CME. And I have the number up here and it's on the board as well for those in the room. This is just a reminder of what's coming up next. We have some fellows who will be giving their end of year talks. And at the beginning of June, we'll have Joe Wu here, who is going to be giving the annual Calabrese lectureship, and excited to have him join us in a little bit over a month. And so these are our disclosures and accreditations. Just to remind our faculty that we have several upcoming clinical town halls and faculty meetings that are on your books, and do your best to attend those. And we also will be, with Lauren's leadership here and Catherine and a few others, we are going to be, when we end this academic year, we'll be moving to a different time slot and day for next year, and more information will come out on that, and we'll get the grand round schedule on your calendars, which in September will be on Wednesdays at noon, and with lunch. So with that, I'm going to introduce Lauren Baldessari, who is the director of our cardiovascular imaging program and cardio-oncology programs, and she'll tell us a little bit about John.
Great. Good evening, everyone. It's my distinct pleasure and honor to introduce to you our very special cardiovascular medicine grand round speaker today, Dr. Jonathan Weinsaft, who's an esteemed physician scientist, an expert and a leader in the field of cardiovascular imaging, most notably with his immense contributions to the field of cardiac MRI, and is currently professor of medicine in cardiology and radiology, and the chief of the Greenberg Division of Cardiology at Weill Cornell Medical Center at Cornell Medicine and New York Presbyterian Weill Cornell Medical Center. He's also the endowed Antonio Gatto Jr. MD Professor in Atherosclerosis and Lipid Research. Additional leadership roles at Cornell have included director of the cardiac MR and cardiac imaging programs, director of the Advanced Cardiovascular Imaging Research Lab, co-director of their T32 fellowship program, and director of the cardiac MRI program at Memorial Sloan Kettering Cancer Center, where he also holds a faculty affiliate appointment. Dr. Weinsaft completed his undergraduate and graduate studies at NYU, where he also subsequently received his medical school degree. He went on to complete internal medicine residency and cardiology fellowship at New York Presbyterian Weill Cornell Medical Center, and subsequently completed advanced clinical and research fellowship in cardiovascular imaging and cardiac MRI at Duke University Medical Center, where he was then brought on as faculty. In 2005, luckily for me, because it was right before I started my internal medicine residency at Cornell, Dr. Weinsaft was recruited there as a multimodality imager, and importantly, to newly establish the cardiac MRI program there. At the early stages of his career, he received numerous awards, including AHA Young Clinical Investigator Award, the ASNC Young Investigator Award, Doris Duke Charitable Foundation Clinical Scientist Development Award, and was named the Michael J. Wolk Foundation Clinical Scholar. He has held over the years and currently holds many PI and co-PI grants, including multiple R01s, amongst others. He holds over 150 peer review original research publications, as well as many other reviews, editorials, consensus documents, and book chapters in multimodality imaging, including CT, echo, nuclear, and of course, MRI. His research has set the standards in the CMR field, establishing the importance and value of CMR for thrombus imaging, tumor assessment, mitral valve assessment, infarct imaging, as well as CT for evaluation of ischemic disease, research in aortic aneurysms, and many, many other contributions. He has also importantly mentored an extraordinary number of trainees over the past 2 decades, serving as a mentor for their many extramurally funded training grants. On a personal note, I had the opportunity to first learn from Jonathan about what at that time was the emerging field of cardiac MRI during my internal medicine residency. shaping my choices and career path in my subsequent cardiology fellowship training, and to focus on advanced cardiac imaging, and as well as to pursue additional advanced cardiac imaging back in New York with him at Sloan Kettering and Cornell. This was an amazing year for me to learn by his side and to receive his clinical and research mentorship gave me the skills and knowledge to pursue my career here. Thank you, Jonathan. Thanks for taking the time out of your busy schedule to visit us today. We're looking forward to your talk on cardiac MR for diagnosis, therapy, and risk stratification of neoplasms and thrombus. Welcome, Dr. Weinsaft.
Thanks very much, Lauren. Dr. Velasquez, many colleagues and collaborators, Dr. Humphrey, it's truly an honor and a privilege to be here today. Here are my disclosures. I'm going to be spending the next hour speaking about the trajectory of our laboratory's work. Initially training at Duke with mentors such as Dr. Velasquez, going on to Memorial Sloan Kettering Cancer Center and Cornell, where I've had the good fortune to work with Dr. Baldessar and many others. And I'm going to be tracking that trajectory with a focus on one area of our research over the past 2 decades, specifically with focus on cardiovascular masses and the utility of CMR to uniquely define both diagnosis as well as prognostic outcomes for these patients. Before starting, I think we should define terms, because unlike many other modalities in cardiovascular imaging, CMR can be many, many different things simply by changing the order, frequency, and pattern in which we apply radiofrequency pulses to the heart. But like none other, it can uniquely identify tissue characteristics within a given structure. And it can integrate those things with more conventional assessments of function as well as anatomy and flow. And what I would posit to you today is it is that ability, namely the ability to define tissue characteristics of a given mass, that can uniquely place CMR as a critically important tool and can inform both diagnosis and outcomes for our patients. So why use cardiac MRI for masses? It's not simply the ability to assess cardiovascular function, namely how the mass impacts cardiovascular performance or how it may impact valvular function, but its ability to assess underlying tissue properties of that mass, namely the vascular supply to the area, as well as the impact of vascularity on lesion growth and propagation. And we'll be talking about that work today. With regard to background of our work, I would put a simple premise forward. Namely, when we've sought to address clinical questions, we've used imaging as a tool, and we've used imaging as a tool to assess uncertainties with regard to treatment and outcomes of our patients. It's that clinical position which has informed the questions that we ask. When I started at Duke nearly 2 decades ago, a fundamental question was that related to left ventricular thrombus. We knew that it provided a substrate for embolic events and a rationale for anticoagulation, specifically in patients with advanced heart failure. What was also known is that whereas patients with heart failure were at increased risk for stroke, diagnostic utility of conventional imaging was limited. Specifically, if one looks at large-scale outcomes data in terms of anticoagulation based on impaired ejection fraction alone, one can see in terms of data from large-scale outcome studies, very discordant results. Some studies suggested anticoagulation to provide benefits, whereas others did not. And one fundamental reason for this, we believe, was the approach used to identify thrombus within the heart. Nearly all studies to date had identified thrombus based on morphology or anatomic appearance. And traditional approaches at the time had used ultrasound, namely identification of thrombus based on morphologic appearance on those ultrasound images. That can be straightforward when thrombus is protuberant or large, can be more challenging. It can be particularly challenging the left ventricular apex, an area in which thrombus is known to form, but can be certainly challenging with regard to near field and other artifacts. We applied a conceptual premise to our work, and that was the premise that whereas thrombus may vary based on shape or size, it can be intrinsically defined by its avascular tissue properties. We also knew that the mechanism of enhancement in a given area was predicated based on distribution of gadolinium, which is an extracellular contrast agent. In the setting of normal myocardium, gadolinium has a low volume of distribution. In the setting of an infarct, that volume of distribution markedly increases, resulting in the phenomenon of late gadolinium enhancement. But thrombus, irrespective of its shape, irrespective of its location, and irrespective of its size, is intrinsically avascular. And as such, there's no vascularity within which to deliver gadolinium to a given space. We leveraged that approach in designing a specific pulse sequence in which we could tailor our inversion pulse to specifically null thrombus or avascular tissue. By modifying the inversion pulse that we applied, we could make the thrombus appear selectively black or null, predicated based on the absence of gadolinium in that area. We then undertook, with collaboration and guidance from Dr. Velasquez and others at Duke, a series of studies to validate and test the concept that late gadolinium enhancement imaging would provide incremental and valuable insight with regard to both prevalence, structural risk factors, and outcomes for patients with known or suspected left ventricular thrombus. When we undertook our studies, we expected to find the images that one can see on the left, meaning circular or protuberant thrombus in left ventricular apex. But what we found quickly was that thrombus could be present in other areas in patients with impaired ejection fraction, as shown on the examples on the top right and the lower right. All three of these patients had histologically proven thrombus at time of surgical exploration. In a subsequent study looking at prevalence of thrombus, we demonstrated that it was present in nearly 10% of patients with impaired left ventricular dysfunction. In a series of nearly 800 patients imaged at Duke University, we found that prevalence of thrombus was 5-fold higher in patients with ischemic cardiomyopathy as compared to those with non-ischemic cardiomyopathy, despite nearly identical ejection fractions in the two groups. And that differential prevalence held true in multiple means of stratifying the groups. Here you see data on the right stratifying groups based on tertiles of ejection fraction, again showing marked increases in prevalence among the ischemic group. When we looked at this cross-sectionally, we were able to demonstrate that extent of late gadolinium enhancement, meaning fibrosis within the wall of the left ventricle, was independently associated with likelihood of thrombus formation, and it was additive to contractile dysfunction. So what you can see on this plot is the three-dimensional representation looking at wall motion score as well as extent of late gadolinium enhancement, showing both to be additive with regard to their risk factor prediction for thrombus formation. In a subsequent study, after moving back to Weill Cornell Medicine, we looked at a series of 121 patients, all at risk for left ventricular thrombus. Here, we're leveraging the power of late gadolinium enhancement imaging, initially validated in our initial study at Duke University, and using it as a reference standard to compare conventional anatomic imaging approaches, non-contrast echo, contrast echo, and cine-CMR, all of which were performed prospectively, all of which were performed using a dedicated and tailored imaging protocol, each of which were independently interpreted in a dedicated core lab at Weill Cornell. And so I would ask the audience, which of these patients has a left ventricular thrombus? I'll tell you that in both cases, each of them was read as negative by our dedicated echo core lab. One can see when we look closely that the image on the right, sorry, my slides aren't playing. The image on the right, patient B, demonstrates a filling defect in the left ventricular apex, whereas patient A does not show anything definitively. When we look more closely at patient A, one can see that the cine-MRI, or the functional MRI, which also identifies thrombus based on its appearance, also demonstrates lack of a discrete mass. But when the patient was imaged using tissue characterization, one can see a focal avascular mass there, which is consistent with what was seen as thrombus at time of surgical exploration. With regard to patient B, this was an individual paired ejection fraction who presented after stroke. One can see again that filling defect in the left ventricular apex, which was deemed negative at time of core lab interpretation. But what one can see on the Cine MRI, again, agrees with the anatomic imaging. That being said, the tissue characterization clearly demonstrates an avascular mass, which resolved after anticoagulation. So when we compared these prospectively overall, we demonstrated in terms of this study that anatomic imaging, irrespective of modality, was suboptimal, irrespective of approach used, irrespective of whether it was contrast echo or non-contrast echo, namely the additive value specifically related to tissue characterization in terms of approach. Extending on this work, we've performed several studies, again, looking at prevalence as well as structural predictors of thrombus, trying to discern using late gadolinium enhancement as a tool to discern information with respect to mechanism. In a subsequent study looking at over 200 patients who were post-myocardial infarction, we again demonstrated that thrombus remains common in the current era and that it is strongly associated with extent of fibrosis, specifically in the left ventricular apex, and was rarely associated with traditional risk factors, such as left ventricular aneurysm. To understand this further and to develop algorithms in order to screen patients so as to understand who might be most in need for left ventricular thrombus imaging by tissue characterization, we then used machine learning to better understand functional characteristics of the left ventricle. These are automated tracking algorithms demonstrated at Weill Cornell and developed at Weill Cornell in an early study. And what we demonstrated using this was that strain impairment or progressive strain impairment from the base to the apex of the heart was strongly associated with likelihood for formation of thrombus, and that using impaired contractile function scores, irrespective of whether based on wall motion or strain, could adequately identify all patients in need of further imaging by late gadolinium enhancement, while screening out nearly 50% of the cohort in whom no additive value was of need. Does this matter? Absolutely. In a series of outcome studies, here's data from Duke, we performed subsequent studies at Weill Cornell. Data demonstrated that patients with thrombus on late gadolinium enhancement imaging were strongly associated with risk for subsequent embolic events, and that many of those patients had negative conventional imaging, again, adding to the value of LGE. In more recent work by our group, we've applied this for thrombus in the right atrium, specifically for catheter-associated thrombus in cancer cohorts, again demonstrating additive value of the tissue characterization method. Most recently, we're particularly focused on asking the question of whether risk, anticoagulation strategies, and outcomes is independent of the finding of thrombus at a given time point on imaging. Namely, asking the question as to whether long-term thromboembolic risk in a given patient is equivalent if risk factors for the thrombus are present, even if the thrombus itself is not present at the time of imaging. Again, this is leveraging initial studies done at Duke, but using newer techniques. What's shown here on the bottom left is work done in conjunction with Oliver Wieben, biomedical engineering at University of Wisconsin, so as to explore the impact of anterior wall myocardial infarction on thrombus formation using four-dimensional flow. And we've also done work in collaboration with Alex Merkler, others in neurology, to understand embolic outcomes and risk for stroke among patients with unrecognized myocardial infarction. In that work, we've demonstrated that risk for stroke in these cohorts is strongly associated with late gadolinium enhancement, even if thrombus is not present at the time of imaging. So perspective matters very, very much. I've talked to you initially about some of the early work that we've done at Weill Cornell in terms of the work that we have done to use late gadolinium enhancement imaging as a tool to differentiate thrombus versus neoplasm simply based on tissue properties. Approximately a decade ago, we extended our lab's work beyond that of Weill Cornell Medicine to that of Memorial Sloan Kettering Cancer Center. And in doing so, we've changed our perspective and broadened our perspective in terms of our approach to cardiac masses. Again, similar to our work in terms of left ventricular thrombus imaging, we focused on cardiac metastases. We focused on these because first, they're far more common than primary cardiac neoplasms, as is the presence of thrombus in patients with advanced cancer. Much like our work in terms of thrombus, we're focused on a growing population at risk. As has been shown, nearly 17 million Americans live with cancer. We know that this population is growing, and this is resulting in a large number of patients who are surviving with regard to experience the consequences of advanced cancer and its complications. And like thrombus, accurate identification of mass types is challenging on conventional imaging. But this is critical to guide both anticoagulation as well as anti-cancer therapies. And finally, we started with the premise that imaging predictors of therapeutic response based on conventional imaging alone are inadequate, and that patients with these masses are at long-term risk for heart failure, arrhythmia, and mortality. So this is an important clinical question. Much like the earlier work I showed you, CMR is particularly well suited to address this question, because when we're speaking about cardiac masses in these cohorts, it's a tool that's able to identify masses within the heart or structures within the heart with high spatial as well as functional resolution. Now, there are four major modes of spread, which can explain the high prevalence of cardiac metastases in this population. First, traditional cancers can spread via transvenous extension. These are traditionally masses that can extend via the inferior vena cava or superior vena cava, and it's characteristic of renal or hepatocellular carcinomas. Cancers can also spread via transvenous extension by the pulmonary veins, as shown here. Here's a lung adenocarcinoma coming through the right upper pulmonary vein. Here's another example through the left lower. Cancers finally can spread by direct invasion, and this is typically associated with pulmonary parenchymal involvement, either primary or secondary lung neoplasms. And finally, via hematogenous seeding. So here's an example of a patient who is referred to us with new onset asymmetric hypertrophy of the infraseptum. And certainly in a cancer patient who presents with new onset asymmetric hypertrophy is shown high suspicion for metastases. So all of these modes of spread can result in cancer metastasis to the heart, which, as stated earlier, is a very common clinical dilemma and clinical problem for advanced cancer patients. Finally, as stated earlier, here's another example of hematogenous seeding. Here's a woman with pancreatic cancer, as shown here, with a mass in the right ventricle, diffusely enhancing. So when I spoke to you earlier, I said that the fundamental advantage of CMR, or fundamental strength of CMR, is its ability to address fundamental questions with regard to vascularity. Keeping it simple, CMR can uniquely provide tissue characterization information with regard to whether or not a given mass is vascular or not. And in doing so, it can inform treatment and inform therapies. If vascular, intrinsically, a mass can be defined as neoplasm. Now, neoplasm requires vascularity for both presence as well as propagation and growth, whereas both thrombus and vegetation do not. And whereas late gadolinium enhancement can identify thrombus based on its avascularity, it is also well suited to identify the converse. Whereas thrombus is avascular and does not take up gadolinium intrinsically by its intrinsic nature, cardiac metastases require that vascularity for growth. So by applying that same pulse sequence that we designed for identification of thrombus, namely selectively nulling of avascular tissue, we were able to develop a tool that could then be systematically applied to identify presence of thrombus, growth rate, presence of neoplasm, as well as growth rate and therapeutic response of the two. So we started out with a quiz earlier in our discussion. Which patient has a thrombus? Here's another question. Which of the two has a neoplasm? And what I would argue to the audience today is that based on conventional morphology alone, it is near impossible to make that distinction. Both patients have a mass in the right atrium. Both patients have a mass which is somewhat irregularly shaped. And based on morphology alone, this is a challenging diagnosis. But if we look at patient A, we can see that the mass on our pulse sequence is diffusely enhancing, intrinsically vascular in terms of its composition. So this would be a mass that we would identify as neoplastic by its intrinsic etiology. If we look at patient B, one can see a very different structure. We can see a mass also in the right atrium, but in this case, the mass is not taking up gadolinium, and it is intrinsically avascular in its definition. So patient A would be defined to have a thrombus, patient B, a metastasis. So I spoke a little bit about perspective earlier, and I would say that that perspective, namely the ability to identify thrombus or neoplasm based on late gadolinium enhancement imaging, is one that has informed our perspective over the past decade of work. Now, when we started, we began with some premises. The literature at the time had informed us that these are very common, but these are typically poor prognostic lesions, typically associated with effusion, so you can find company that they keep in order to make the diagnosis, and that there were specific etiologies that this diagnosis should be reserved for. What I would make the case to this audience today is that new insights, which have been enabled by CMR tissue characterization, have challenged some existing paradigms regarding both diagnosis, clinical sequelae, and prognostic impact of cardiac masses. So I'm going to go through some literature in terms of some of our work that has systematically addressed this. In an initial study by our group, we simply sought to ask the question of what is the company that these masses keep? Are there specific patterns? Are there specific diagnoses? And are there specific accompanying signs that can be used to identify and stratify risk among patients with cardiac metastases? To do so, we studied 60 patients, all of whom had stage 4 advanced cancer, all of whom underwent CMR using a tailored prospective protocol. In each patient, we performed functional imaging, and we performed dedicated tissue characterization imaging using the late gadolinium enhancement approach that I described. What we found was that cardiac MRI tissue characterization showed these masses to be highly variable in terms of their location. There was no predilection. Nearly half occurred in the right side of the heart, nearly 40% in the left, and there were often concomitant lesions. We also demonstrated, and I'll be coming back to this, whereas tissue characterization demonstrated these masses to be uniformly enhancing, again, these are vascular masses requiring vascularity for growth, the pattern of vascularity within these cardiac metastases was somewhat variable. And I'm going to go back to why that is important in subsequent talks. What we also learned is that the masses or the metastases didn't read the textbooks. They occurred with cancers that were not deemed typical for cardiac involvement. Both adrenal, CNS lesions, and primary hepatic lesions all had cardiac involvement in some cases. And that affected cases, patients often lacked classic ancillary findings. Only a quarter had pericardial effusions, only 50% had pleural effusions. As a next step, we then asked the question of prognosis. Now that we had a tool to identify reliably presence of metastases and to differentiate those potentially from cardiac thrombus, could we use this as a tool to actually predict cardiovascular outcomes in these cohorts? We studied 126 patients, all of whom had systemic non-cardiac cancers, all of whom underwent cardiac MRI. 50% had cardiac masses, either tumor or thrombus, as defined by the reference of late gadolinium enhancement. And these patients were matched to controls. Our control matching was based on primary cancer diagnosis, age, and gender. We first demonstrated that our visual assessment agreed well with actual quantitative analysis. Both SNR and CNR, quantitative measures of contrast uptake, were markedly higher in patients with cardiac metastases or visually assigned cardiac metastases, consistent with anticipated results. With regard to outcomes, we found that differentiation of tumor versus thrombus based on presence or absence of enhancement strongly impacted actual risk for adverse clinical outcomes. Mortality was markedly higher among patients with CMR-defined neoplasms versus thrombus, a hazard ratio over 3. What we also demonstrated was that prognosis did not differ when we simply characterized lesions based on size, as measured based on area, diameter, or volume. With regard to comparison of tumor versus thrombus, we found that patients with thrombus had similar mortality risk versus cancer-matched controls, whereas those with cardiac metastases tended to have worse outcomes. Now, this notion, the notion that that tissue characterization provides prognostic value, has subsequently been validated not just by our group, but by several others. Here's data from Chetan Shenoy, not just looking at a cancer cohort, but looking at a large cohort of nearly 1,000 patients, all of whom were referred for cardiac MRI to assess cardiovascular masses, demonstrating that prognostic outcomes were far worse in terms of risk for all-cause mortality among patients with CMR-defined cardiac malignancies as compared to other groups, irrespective of whether termed thrombus or pseudomass or benign tumor. And the prognostic value of CMR in this patient population was incremental to conventional clinical characterization, both in patients with known cancer as well as in patients without known extracardiac malignancies, again supporting the utility of the tissue characterization method. So we've talked a lot about tissue characterization. What about alternative tissue characterization approaches? This is a particular interest of ours, both at Sloan Kettering as well as Cornell. In an initial study looking at this concept, we compared CMR to whole body FDG PET. We looked at 121 patients with systemic cancer in this registry, undergoing both whole body FDG PET as well as CMR within a narrow 3-month interval. Imaging exams, much like our earlier contrast-enhanced echo study, were interpreted by independent core labs, first visually as well as quantitatively. With regard to CMR, again, we used the reference of late gadolinium enhancement to identify thrombus versus tumor and to identify presence of tumor based on vascularity. With regard to PET, we identified malignancy based on increased FDG uptake in a focal region. And again, this was independently interpreted. Patients in both cohorts were followed for prognostic risk assessment. This is what we anticipated to find. Here's a patient with a large mass in the right ventricular outflow tract. One can see enhancements in that region. One can see FDG uptake in terms of PET-CT. But when we looked at overall diagnostic performance, we found that in relation to the reference standard of late gadolinium enhancement, PET yielded moderate sensitivity and accuracy. So why was this? A key reason for discordance is that PET sensitivity varied in relation to extent of avascular tissue composition on late gadolinium enhancement. Again, as I stated to you earlier, when we found metastases on CMR, many times there were areas of enhancement, but also areas of non-enhancement or tumor necrosis. So mixed enhancement or and non-enhancement within a given mass. What we found is that for cardiac metastases that were diffusely enhancing, as shown on the example on the left, PET performed extremely well, identifying all lesions demonstrated by LGE-CMR. For patients with ring enhancing or minimally enhancing, modestly enhancing lesions, PET also performed extremely well, as shown here on the example on the left. But for tumors in which there was minimal enhancement, but large areas of lack of enhancement, otherwise termed tumor necrosis, PET performed poorly, consistent with the fact that there's variability in terms of metabolic activity in tumors and in given areas. And we'll talk about why that is important. And as expected, in areas of thrombus, no FDG uptake was seen. With regard to outcomes, what we also found is that whereas late gadolinium enhancement again predicted risk for all-cause mortality, stratification based on PET yielded lesser differences, attributable to the fact that approximately a third of these cases were not identified. We then asked a fundamental question. If we know that cardiac metastases will intrinsically enhance, but we also know that pattern of enhancement with within these metastases varies, can we use enhancement pattern as a means to predict outcome and prognosis? Now, this was informed by the actual cancer literature, which has shown us that in regions of tumor necrosis, in patients with tumor necrosis, there's adverse prognosis. These are quicker growing tumors. These are faster growing tumors. These are tumors that outstrip their intrinsic vascular supply. So to address this question, we then went back to our registry. We studied nearly 224 patients, again, the same sort of study design, patients with cardiac metastases and without cardiac metastases, matched 1-for-1 based on cancer stage as well as etiology. And we carefully categorized not only the presence or absence of enhancement, again, absence of enhancement would indicate a thrombus, presence of enhancement would indicate a neoplasm, but we also classified based on enhancement pattern, namely categorizing patients with both diffuse enhancement, or the diffusely bright lesion that lit up on PET, and lesions with heterogeneous enhancement, meaning admixed enhancement and non-enhancement within a given lesion. We performed prospective follow-up in these patients for both mortality as well as clinical events. Increase of interest, first, with regard to embolic events, we found that patients with right-sided lesions were markedly at risk for actual adverse outcomes in terms of pulmonary embolism, consistent with the fact that these patients have a nidus for events. But with regard to outcomes in terms of all-cause mortality risk, we demonstrated that patients with heterogeneously enhancing lesions, meaning admixed enhancement and lack of enhancement within a lesion, were at increased risk for mortality as compared to controls, whereas those with diffusely enhancing lesions had a much better prognosis, which was similar to those of cancer-matched controls. Again, moving beyond presence of binary presence or absence in terms of diagnosis, but actually to more refined risk stratification in terms of outcomes. In subsequent work, we've tried to leverage this even further. If we know, or given that we've demonstrated that patients with diffusely enhancing lesions seem to have better prognosis, and that heterogeneous enhancement seems to indicate a worse cardiovascular phenotype and a worse outcome among these affected patients, can we leverage the power of multiparametric CMR to gain a better quantitative assessment of this and to gain better insight in terms of personalized care and personalized therapeutic decision-making for these patients? In our most recent study looking at this question, we've looked at nearly 500 patients. In this study, we're again applying the same sort of study design for identification of the presence or absence of thrombus and for identification of the presence of cardiac metastases, namely late gadolinium enhancement as the reference standard within which to identify the presence of a neoplasm. If it enhances, it's a metastasis. That's by definition how we're assigning our binary diagnosis. But we've gone beyond that in our most recent data in applying quantitative first-pass perfusion. So together with using late gadolinium enhancement, we actually are looking at contrast uptake patterns within these lesions. As you can see on the examples shown on the right, these are all examples with pathology-verified cardiac metastases. One can see that whereas they're all enhancing, they're all taking up gadolinium, the pattern, the magnitude, the contrast uptake pattern markedly differs. The examples on the lower right show prominent enhancement, very, very prominent and markedly increased slopes with regard to first-pass contrast kinetics. The examples on the left show minimal enhancement. There's some contrast uptake, but as you can see, these slopes are very different. And the magnitude of vascularity is very different in the histopathology images on the bottom. Namely, the examples with high contrast uptake have extensive vascularity as demonstrated on histopathology. The examples with low contrast uptake have minimal vascularity and extensive tumor necrosis. So what have we found? What did we find in terms of actual prognostic outcomes? What we demonstrated was that with regard to actual outcomes, you can again most accurately quantify, differentiate based on presence or absence of enhancement using the initial binary term of late gadolinium enhancement CMR. There were further differences, more clear differences between cases and controls using LGE as a reference in terms of the Kaplan-Meier on the left, whereas both semi-quantitative perfusion and visual perfusion scores performed somewhat suboptimally in relation to late gadolinium enhancement. However, once the mass was identified as being a metastasis or not, what we demonstrated is that you can further differentiate prognostic outcomes. Here, what you can see in terms of the Kaplan-Meier curves on the bottom is that among patients with the greatest perfusion, meaning the patients in the highest tertile of contrast uptake, mortality was equivalent to cancer matched controls. That's the Kaplan-Meier on the bottom right. Among the patients with lowest perfusion, as shown on the bottom left, mortality was markedly higher as compared to their matched control subgroup. Again, demonstrating the concept that presence of tumor necrosis or presence of low vascularity on perfusion CMR is a powerful modifier of outcomes among these patients. I think what's also important to see is that with respect to follow-up duration in these patients, actual median survival was nearly 2 years. Again, consistent with the concept that these patients are living longer, they're doing better, and that in patients with the highest perfusion tertiles, median survival was nearly 3 years. When we look at multivariable analysis, this is multivariable modeling, looking at prognostic predictors among this group, we demonstrated that impaired lesion vascularity quantified by perfusion CMR augmented risk for death independent of cancer etiology, as well as anti-cancer treatment regimen. So in the time that I have left, I'm going to shift gears a little bit and talk about some ongoing and future work by our group. So first, we're extremely interested, very interested in using parametric mapping methods to better quantify tissue properties of these masses and to better understand what their therapeutic response is, as well as to stratify outcomes in a more precise manner. Here's an example of that. This is a 54-year-old man, metastatic sarcoma, 3 years status post-targeted biologic therapy. Here you can see the baseline image here and the pre-contrast T1 mapping that we've performed. And we're using some of these mapping data to look at outcomes in this cohort. But what I would point out to you is, again, this is what would be termed a long-term survivor in this cohort. We're also extremely interested in better understanding therapeutic response. And I think this is particularly exciting data in terms of things. We're seeing more and more of these patients with who are surviving long-term with these masses, and we want to better understand why this might be. Now, here's an example of a long-term survivor and an individual in whom the mass is growing and increasing slowly, but increasing with time. That being said, a 4-year outcome in this individual is far beyond what the textbook had shown us when we started this journey. Of additional value is the fact that we're seeing more and more of these patients who are responding to targeted therapy. So here's an 80-year-old man, prostate cancer, treated with targeted immunotherapy. Here we can see a large enhancing mass in the right atrium at baseline, 1.5 years after follow-up, near resolution of this mass. And we now have 2-year data in this individual as well. So we want to better understand this, both in terms of its mechanism, as well as the utility of predictive tools to guide us in terms of this. I spoke a little bit about embolic events earlier. This is of relevance to cancer populations, both with thrombus as well as with cardiac metastases. Here's data from our group looking at cancer-associated thrombus in patients with central venous catheters. These are nearly 600 patients in whom we're studied, all of whom have CMR-verified thrombus using the technique of late gadolinium enhancement, demonstrating a nearly 5-fold risk of pulmonary embolism among patients with thrombus as compared to matched controls. And of interest, nearly all of these patients were on baseline anticoagulation at the time of their event. So we're learning both that we have an accurate tool for predicting embolic events, predicting presence of thrombus in these patients, but also recognizing that our tools for treatment are not necessarily sufficient. We're going to be studying this more in years to come. We're also partnering with Keith Manning, with others at Penn State, to understanding what risk factors for thrombus in these patients might be. I spoke to you a little bit about late gadolinium enhancement as a nidus for left ventricular thrombus. What we don't fully understand is what the nidus for thrombus formation on central venous catheters are. We believe this is a major problem in cancer populations. We're using computational modeling to better understand this, and we certainly expect important insights to be gained. What the goal is to develop more precise measures for predicting patients at risk, as well as more informed approaches for guiding where our catheters should be. Finally, in the time that I have left, I'm going to speak a little bit about a new technique that we've developed at Weill Cornell, or I should say refined at Weill Cornell. It's been developed by others over years, which I think is particularly valuable. We're using it increasingly for assessing patients with cardiac masses, as well as for assessing cardiovascular performance, both in cancer populations as well as others. And that's the utility of CMR tissue characterization to move beyond fibrosis or perfusion assessment and to begin to look at metabolism and oxygen utilization. We're particularly excited about a tool called quantitative susceptibility mapping. This is a tool that's capable of assessing cardiovascular oxygenation. And not to get too much into physics, but I'll just step back a little bit for all those who remember back to medical school. Hemoglobin consists of 4 iron groups, which when in the oxygenated state are covered and not exposed. But when hemoglobin becomes deoxygenated, those oxygen groups egress, exposing iron and changing the magnetic properties of the substance. We can exploit that. We can utilize that in the magnetic field environment using a technique called quantitative susceptibility mapping. This is similar, but potentially incremental to traditional bold techniques. I won't go into the details of this. I will simply thank Dr. Jihao Li and Yi Wang, as well as Pascal Spinsmai, who are working with our group very extensively on this. To state it from a big picture perspective, it leverages the power of traditional gradient echo imaging, performs phase unwrapping, and can generate a map that quantitatively represents the magnitude of exposed versus unexposed hemoglobin. In an initial study validating this approach, we've compared cardiac quantitative susceptibility mapping to right heart catheterization. This is done in a cohort of patients with known or suspected heart failure. This is not a cancer cohort, but we are applying it on cancer cohorts. And we're demonstrating very good agreement between oxygen saturation measured invasively versus what is seen on our quantitative susceptibility maps. I've given you one example. I can provide others. As you can see, the left heart is dark, the right heart is bright, and the differences in that darkness or brightness stems from the differences in susceptibility, namely oxygen saturation. In our initial validation study, we demonstrated close correlations with an R value of 0.87 versus invasive measurements, as well as the ability of the QSM technique to differentiate between patients with and without left ventricular dysfunction. Here's data from Rob Zhang, our advanced imaging fellow this year, further validating the technique, demonstrating good agreement between quantitative susceptibility and invasive catheterization derived cardiac index, and improved magnitude of agreement for QSM as compared to conventional CMR imaging using flow assessment. I won't share this in detail. This is not yet published, but we've leveraged the power of this quantitative technique to not just look at indices of ventricular performance, but also to look at outcomes. So here's data in 115. These are non-cancer patients. We also have these data in patients with cardiac masses, but simply looking at impaired oxygen utilization as a risk factor for actual all-cause mortality. So what would be the mechanism for this? This is fundamental cardiovascular physiology. Impaired left ventricular performance or right ventricular performance is going to result in greater desaturation within the right ventricle. We measure this on our invasive cath labs on a routine basis when we do right heart catheterizations. And when we use QSM as a means to identify impaired oxygenation in the RV, these are in patients with PH, we can powerfully predict risk for death. And that risk prediction is independent of both left ventricular as well as right ventricular dysfunction. We're currently preparing this for manuscript preparation. And finally, I'll say that the predictive value of this tool is also independent of pulmonary arterial pressure in and of itself. With regard to utility of this technique, I've talked about QSM as a measure of oxygenation, but just recognize that this tool is also sensitive for both detection of hemorrhage as well as calcium in masses. Calcium is highly diamagnetic, and it's certainly a mark of thrombus chronicity, which can occur in patients with chronic thrombus, but it can also occur in an array of malignant lesions. And so we're applying this. And finally, that exploratory work by our group is looking at this in terms of myocardial tissue properties. So what are the key points in terms of conclusions? First, that cardiac masses broadly impact clinical decisions and outcomes, but can be challenging to assess based on conventional imaging. I hope I've demonstrated that CMR provides unique tissue characterization of vascularity, which intrinsically can be used to differentiate tumor from thrombus. And then among patients with cardiac metastases, we're seeing longer life expectancy, and we're also demonstrating that beyond binary diagnosis, tissue necrosis or impaired vascularity within a mass is an adverse prognostic marker that predicts both embolic events and mortality. I want to thank all of the people in our lab, the many, many collaborators within our group in terms of the biomedical engineering group in Ithaca, as well as external collaborators, some of whom are here today. Keith Manning has contributed to much of this work. Jay Humphrey, who is working with us on aortic related analyses, as well as others in the biomedical engineering space that have made this possible. And I also want to thank the array of trainees who have made critical contributions to this work and have gone on to lead major programs at Yale, as well as elsewhere. Specifically, Lauren Baldessar, who incredibly productive leader in the field of CMR. I had the good fortune for her to train with us for a year, as well as Attila Feher, who's with us today, also has worked with our lab as well. I want to thank the funding agencies who made this possible, and I want to again thanks everyone in the audience and Dr. Velasquez for this kind invitation.
Water and take these away.
Oh, sure.
That was great. I wonder about tissue characterization, tumor characterization with photon counting CT, with or without gadolinium, and how that might compare to MR imaging.
So that's a great question, and we're starting to look at that as a tool. I think that a couple of things stand out in terms of utility of CMR in this space in comparison to traditional CT-based methods. So first, from a conceptual level, what we are finding is that many of these patients are living longer and longer with tumors, including patients with cardiac metastases in whom we see marked regression, as well as, in some cases, resolution of these masses. And so it is critical, as we've learned from the mediastinal radiation space, whom we know that radiation for Hodgkin lymphoma can be curative, but can result in marked long-term risks for cardiovascular damage in terms of atherosclerotic plaque development and otherwise, that radiation dose reduction is important. So, from a holistic standpoint, as we follow these patients, radiation avoidance is key. The second, from an imaging standpoint, I would point out that the major strength of CMR for this purpose is its ability to apply that 180-degree inversion pulse, and in doing so, to markedly increase the magnitude of difference between areas of enhancement that are going to recover markedly quicker versus those with lack thereof. Now, that may change in the setting of photon counting CT, but the data's out on it, so we don't.
Awesome, thank you. Great talk. So I have two questions. One is about the metastatic lesions oxygenation. And as you know, tumors normally use Warburg effect and anaerobic kind of metabolism through glycosylation versus the oxidative phosphorylation. I wonder how much the sensitivity is for that kind of that prognosis that you mentioned, because most tumors use the anaerobic path. The second question I have is actually a dilemma that I always had from my residency out till now, that we always debated that actually metastatic lesions may have a thrombus on top of them, as they actually have platelet aggregation, things like that. And the question was that when you anticoagulate, what happens? Is it bad? Is it good? And I wonder if your studies have shown anything in that regard.
Those are really great questions, and those are tough questions. So first, with regard to tumor characterization via quantitative susceptibility mapping. So I didn't get into the details of the physics, but I would say that the technique has particular strengths for three applications. The first is assessment of oxygen utilization or of oxygenation within given structure. And from a holistic standpoint, I'm particularly excited for its utility to assess ventricular performance, but also to assess myocardial oxygen utilization in heart failure patients and other cohorts, and we're looking at that. But what Dana would tell you is that a key advantage of techniques such as QSM are its ability to assess diamagnetic or paramagnetic substances, such as calcium, as well as hemorrhage within a given area. So am I certain that QSM oxygenation is going to be the holy grail on this? No. But what I do think will be interesting is to better understand tumor biology and tumor characteristics and properties, because as shown in terms of the data on tissue vascularity or tumor necrosis, we are increasingly moving beyond binary differentiation and otherwise. The second question is much more clinically pertinent and comes up very frequently at Memorial Sloan Kettering and such. So as a disclaimer, I'm moving very much beyond evidence-based guidelines. This is very much the area of future research, if we have funding agencies to fund research, and future investigation. I would pose to you that in patients with tumors that are, or metastases that are highly vascular and diffusely enhancing, the rationale for anticoagulation is markedly blunted. And the risk of that anticoagulation in terms of brain hemorrhage and otherwise is substantial, especially in highly vascular masses. So I think in that setting, a rational case could be made to defer anticoagulation. I've had long discussions with oncologists as to whether we should be deferring anticoagulation in patients with heterogeneously enhancing masses. And I think that's the focus of an outcome, a very much needed outcome study.
So that was very impressive work that you described. One of the things that you said early on was that the extent of LGE correlates with the risk of thrombus in the post-infarct setting. And I wonder if you think that's simply a manifestation of the extent of the infarct, so bigger infarct, or whether there's some biological story in there that the drive to fibrosis also correlates with the drive to thrombus formation, something a little bit beyond just the extent of the infarct, but an additional piece to that story.
Well, I think that first I would say that there's much more to the story, that it's simply not based on extent of infarct. And we know that observationally, we see patients with large inferior wall myocardial infarctions who develop functional microregurgitation, but they don't develop massive left ventricular thrombus. So there's something, it is certainly the effect of the infarct together with potentially infarct distribution on blood flow characteristics and otherwise. And we're looking at this in terms of both modeling as well as 4D flow characteristics, blood flow characteristics in the left ventricular apex and other areas, which may be replicated in some scenarios if large inferior wall aneurysm and not otherwise. Now, why the infarct drives the thrombus to form? I mean, this is, goes back to Virchow's triad and others who have studied this. It may be in part due to the fact that the infarct itself is intrinsically thrombogenic. It may be in part due to the fact that infarcted or transmurally infarcted areas are much less contractile than even severely hypokinetic regions. But I would make a broader case in terms of clinical approach to these patients. So the notion that you image a patient that post-myocardial infarction, extensive left ventricular apical fibrosis, contractile dysfunction, nidus for thrombus formation, demonstrated reliably on CMR or whatever tool you want to have. But the patient doesn't happen to have a thrombus at that very 30-second window in which you image the myocardium. The notion that the absence of thrombus at that time point is a rationale to withhold anticoagulation is increasingly called into question, given that we now have novel oral anticoagulants that are much less of a bleeding risk than others. And I know that several groups are looking at that question. I think is a very good study that needs to be looked at in the post-myocardial infarction setting.
Jonathan, maybe I'll take the last question. First of all, congratulations. I am confident that when you walked into my office in 2003 and told me you wanted to study thrombus, I told you to go and do something else. But yet you've built an entire a career and impacted the field dramatically with these studies and really just so impressive, and congratulations. My question is very clinical, which is now that we have these approaches to evaluate metastatic disease as well as cardiac pathology in the heart, cancer pathology. Are you increasingly helping to direct either interventional radiology or interventional cardiology to approach these masses in certain ways, or are you in any way becoming a means to define cancer therapeutics? What works in what time frame? Is that been part of this evolution? Is this becoming a way to stage a response to treatment?
Yeah, so that is the goal. And the goal is to inform mechanistically guided treatments and therapeutics for patient populations, to identify the patient with an affected metastasis in whom we expect to see response, and to also define treatment algorithms, whether it be anticoagulation or targeted immunotherapy. We're seeing very encouraging results in certain cohorts, specifically for diffusely enhancing lesions, which are highly vascular, which we think are more likely to respond to chemotherapeutic agents and otherwise. We've also seen striking responses in terms of immunotherapy and otherwise. But what we do know is that we now have a tool, we have a metric that can biologically assess response of these lesions, and to do so in a reliable manner. So much more to come, and I hope to come in future years with much more data. Thank you.
Thanks. Crazy how you've kind of advanced this